If you have a single tooth, it's not too difficult to estimate the nasal
sẽ không
distal
quá khó để xác định cái chiều gần xa của
and do the
implant.
implant placement here. What about if your patients have
Nếu mà bệnh nhân của bạn mất nhiều răng thì sao?
For example, here we have
Như vậy ca đây ta có một ca
and here we
khá
are
là hay
also
khi mà
missing the molars.
bệnh nhân mất
So
toàn
how
bộ
do you
khối
set
răng
up
hàm
the teeth in
lớn
a
phía sau.
position that you can have the cast fossa for for posterior teeth, and anterior you also achieve the aesthetic outcome.
Chúng ta sẽ phải làm sao để chúng ta thiết kế một cái khớp cắn với răng sau. Thế là chúng ta có cái khớp cắn là cúi vào hố rãnh. Chúng ta phải quan tâm đến cái vị trí của răng, tương quan của hai hàm.
Và vị trí răng cửa chúng ta cần đảm bảo thẩm mỹ nữa.
And if you want to place a premolar size implant, the size would be around 7 mm. So you can do a rough estimate based on that. And also you want to consider the opposing arch because that will determine the
trong quá trình gây điều trị ta cần phải cân nhắc cả vị trí răng ở hàm đối chúng ta để nhìn thấy là chúng ta phải cân nhắc được cái vị trí của răng cối lớn, răng số 6 nữa.
What we can do is we can go back to the analog workflow. So after you take your diagnostic test,
trong những trường hợp mà chúng ta không chắc chắn cái việc chúng ta phải làm, cái hoạch chúng ta phải làm.
After you take your diagnostic test, you can have a better idea about the dimension, buccal apicoronally, about what the implant size you want to have.
Chúng ta sẽ tính toán cái khoảng phục hình chúng ta có là bao nhiêu.
So in that sense, you can get the ideal cast fossa relation for the mandible and also for the maxilla, so you can achieve the ideal over general. So that's how we do that in analog workflow. So if you have single tooth, that might be okay if the tooth space is too bounded. But if you have multiple tooth, you want to consider to
nếu mà có một bệnh nhân mất nhiều răng thì tôi khuyên các bạn là nên làm một cái mẫu sát chuẩn đoán.
And here's another case that is about removal. So this is actually one of our lessons case. So as you can appreciate here, the mandible we have a severe periodontitis.
Các bạn nhìn thấy là hàm dưới thì có tình trạng bên chu khá là nặng và hàm trên là một tình trạng mất răng toàn hàm. Vậy chúng ta bắt đầu như nào? Đầu tiên chúng ta sẽ phân tích tĩnh và phân tích bằng chẩn đoán.
Position our incisor edge in the ideal
và
position.
Chúng ta sẽ chọn vị trí diệt cắn răng cửa ở vị trí lý tưởng.
The requirement of ideal vertical dimension respect the
tuân theo mà không thay đổi kích thước dọc. Sau đó chúng ta thiết kế cái hàm thẳng lắp in ra và chúng ta sử dụng nó để áp dụng lên kế hoạch lên của phẫu thuật. Và các bạn có thể thấy là cái sức mạnh của cái nha khoa kỹ số nó áp dụng cho ca này lớn như thế nào.
And one important thing to consider if you have a single dental implant is how much space that we have. So according to the glossary of prosthodontic terms, the space analysis is a treatment planning for the prosthesis, 3 dimensions necessary for restorative material relative to the supporting anatomy. And this can be vertical and horizontal. For vertical, we need to define very carefully. The vertical dimension defined as a crest of the alveolar bone to the opposing occlusal plane. So I think this is really related to what material that you have. Because when you place a dental implant, you want to consider first the biological width, and second is the abutment height, and then above the abutment you have the occlusal material, composite, and also the Teflon, and that all takes the space. And horizontal dimension you will estimate what's the mesodistal and buccal width of the tooth.
Về phía ngang thì chúng ta sẽ đánh giá về khoảng gần xa và khoảng ngoài trong của phục hình.
So for example here,
ví dụ
you
trong
can
ca ở đây
appreciate this is a case that patient has 100% deep bite and very cancer và
hơi can tinh một chút và khoảng phục hình theo chiều đứng rất là thấp.
You can think about if we place a dental implant here, the top molar is really super erupted, so we don't have a good space to do any protrusive or lateral movement. And also patient wants to get a dental implant here. But you can see the space is quite limited. So if you place a dental implant here, the material might fracture, and that's the thing you want to foresee.
chúng ta cũng không có đủ cái khoảng hình, do đó nếu chúng ta đặt
So in class we have a terminology that is called the crown height space, and that is defined as the distance between the occlusal plane and your bone crest. Ideally, you want to get 8 to 12 millimeters according to the literature. But imagine dental implant is not easy to get that space because when you lost your tooth, you might have the opposing tooth supermounted, or you don't have enough space. And ideally, the screw retain crown will require less space, and cement retain crown will require more space. And I wouldn't give a number here, but in general, it's about 5 to 7 meters.
Do đó thì chúng ta sẽ có thể cân nhắc đến phục hình bất vi này.
And another thing to think about is about the crown to root ratio. And in our natural teeth, the ideal crown to root ratio is about 1 to 2, and maximum we can accept is 1 to 1. But in implant dentistry, we have to think it differently because in dental implants we have the osseo integration. So multiple studies they have done with animals and also clinical study, they have found that even if you have a very high crown to root ratio, you will still have the good survival without any major
mà chúng ta có cái tỷ lệ thân chân răng mà lớn hơn nhiều 1:1 như thế này thì đôi khi chúng ta vẫn có thể có cái sự thành công về lâu dài.
Đây là một cái chủ đề mà tôi rất thích bàn luận với các bác sĩ phụ huynh khác của tôi, và cái điều liên quan đến việc là chúng ta sẽ đặt implant sâu như nào. Và các bạn nhìn thấy đây chúng ta có một cái khái niệm gọi là bệ chuyển tiếp, và cái góc bệ chuyển tiếp thì được xác định bởi và cái góc này thì nên là xấp xỉ từ 15 đến 25 độ. Góc bệ chuyển tiếp thì xấp xỉ từ 15 đến 25 độ. Và nếu như các bạn làm một cái bệ chuyển tiếp có góc lớn hơn 45 độ thì sẽ có nhiều khả năng cao là bạn sẽ bị tình trạng tiêu mào xương cổ quanh implant. Và chúng ta sẽ làm gì trong trường hợp này, và chúng ta sẽ cần có một cái profile bệ chuyển tiếp theo dạng cong lên từ từ.
And this is another important slide that we talk about. And this was actually published at University of Pennsylvania. And we talk about critical and subcritical contour. So after you place a dental implant, especially in the anterior case, you can do a provisional crown that will help to form the peri-implant soft tissue. So where is the critical contour?
Vậy thì vùng critical contour là nằm ở đâu? Thì
the critical contour is at the highest spot of your apical margin, your crown apical margin, and that will determine where is your future CJ is coming from your implant. And also we have the subcritical contour that is immediately below the critical contour to the implant envelope, and that will help us to form the peri-implant soft tissue. Either you can be flat, convex, or concave, depending what you like your tissue là
nó cong lồi hay cong lõm.
Cong lồi hay là cong lõm, bởi vì nó sẽ quyết định cái vị trí đường viền của chúng ta.
Keep your soft tissue. You don't want to compress too much your
nếu mà các bạn không muốn là nén mô mềm quá mức, chúng ta có thể để nó ở dạng phẳng hoặc là dạng cong lõm.
So you can appreciate here the critical contour
đây là một cái
will
ví dụ
rest at the
một cái
CJ.
khung hình thật. Ta thấy là
And
cái
the subcritical contour will
nó
be
là cái vùng nâng
slightly
đỡ cái đường viền
concave,
phục
so that
đường
will
viền mô
give
mềm
the
của bệnh nhân,
room to
vùng đường viền lợi của bệnh nhân.
implant processes to
Còn
have
cái
the
vùng
ideal interproximal or facial peri-implant soft tissue.
Vùng subcritical thì nó sẽ là cái vùng mà nó quyết định cái đường viền mô mềm ở xung quanh vùng cổ implant, ở kẽ của implant.
Here is one of my very first dental implant case.
Và đây là một trong những ca implant đầu tiên của tôi.
Tooth number 7 and tooth number 10. They are both dental implants.
Răng số 7 và răng số 10, hai cái răng hàm, hai răng cửa bên.
This is the final crown.
Các bạn có thể nhìn thấy đây là cái khung hình sau cùng.
The soft tissue if you compare 7 to 10. 10 seems a little bit less ideal. So I would say like if during the healing stage we can try to push the tissue a little bit, maybe the outcome will be different. So that's something you have to think about, especially
trong cái quá trình lành thương thì có thể đôi khi chúng ta hơi nén cái mô mềm quá mức. Thì cái này là cái điều mà chúng ta sẽ cần cân nhắc trong cái quá trình chúng ta tạo hình mô mềm.
And the next thing is sometimes you'll run into this kind of case.
Đôi khi chúng ta có thể gặp những tình huống lâm sàng như này để chúng ta có một cái khoảng liên hàm rất là nhỏ như thế này. Thì chúng ta các bạn có thể nhìn thấy rằng là cả toàn bộ cái nhóm răng dưới nó đang trồi lên.
with
và
the
gần như cái đường
anterior
cong
crane.
suy nó bị đảo ngược.
So what can we do? We want to start with the conservative method. So what you can do first is you can consider to reduce or even extract the
chúng ta có thể cân nhắc cái
if
việc là chúng
necessary.
ta có thể giảm
And
mài
this
bớt
means
những
that
cái
you
răng
can do
hay là
some
chúng ta có thể thậm chí là
enamel
nhổ những cái răng trụ quá trội.
And second thing, as Dr. Theo mentioned earlier, we can consider to do a surgical reconstruction of the dental space. And then of course you can consult your orthodontist to help you to intrude the teeth and that will give the space. And lastly, we can consider to increase the occlusovertebral dimension.
Chúng ta có thể tăng cái kích thước dọc để chúng ta bù trừ lại cái việc chồi răng này.
And what about removable case? You will run into cases that patient is completely edentulous. So where do you want to place your dental implants? It's not easy to estimate. If it's a single crown, you can easily picture where you want to place your dental implants. But if it's fully edentulous, you want to start with where your teeth will begin. So first thing I usually do is I estimate the occlusovertebral dimension and make a conventional denture first. And after that, what you can do, there are multiple ways to evaluate how much restorative space is available for dental implant. And the literature show here, first thing you can do is after you do your diagnostic wax out, you can try illumination patient's mouth. And if you like the space, you can melt your wax and use your parallel probe to measure how much space that you have. And from there, you can either trim down your bone or open your bone. And there's another way to do this. You can also deliver your denture first, and you can duplicate your denture or 3D printing a denture and put a visual marker on the top of it and merge with your CBCT. Then put in the software to see how much restorative space that you have.
Và kết hợp với cả phim Cobicity thì chúng ta có thể quan sát được cái khoảng phục hình mà chúng ta có.
So here I just wanted to show the dual scan protocol. And here, as you can appreciate, upper we are missing all the teeth. And here we deliver the dentures to patients first. And then we merge it with the CBCT. So here you can kind of see the fringe and also the teeth position. And in that sense, it can help you to estimate where do you want to place the dental implant.
Cái trường hợp này thì sau khi chúng ta wax xong, chúng ta có thể trồng nó với các cái răng tự nhiên của nhân để chúng ta quan sát được cái khoảng cách chúng ta có so với cái phục hình implant tương lai. Trong những cái trường hợp mà chúng ta muốn thay đổi cái siêu rộng của bệnh nhân thì Comicity theo scan này là một cái công cụ rất là hữu hiệu. Như trong trường hợp này bệnh nhân có một cái khớp cắn sâu.
What I did first was I did the diagnostic wax out at an increased vertical dimension. And after that, I duplicate this wax out and started my tooth preparation. And then I deliver the provisional at an increased vertical dimension.
Lắp răng tạm cho bệnh nhân ở cái vị trí tăng kích thước dọc này.
And then what we can do next is, I think this is really incredible. Like we can put the visual markers on the provisional tube, and then you can scan this together, and you will merge into your CBCT, so you get the ideal implant position, and you know how much space that you have.
Mốc cảm quan để chúng ta có thể quan sát được cái
And another thing we have to think about is if you have fully edentulous patients and
khi chúng ta có một cái hàm bệnh nhân bắt đầu tuần hàm thì và bệnh nhân muốn có một cái hàm cố định trên implant hoặc là phủ trên implant thì câu hỏi đây là bao nhiêu cây implant nên đặt và vị trí của chúng nằm ở đâu.
So for example, you have to think about, are you restoring the upper or lower arch?
Và
If you
chúng ta
are
nên cân nhắc là
restoring
ta
the
nên
upper
phục
arch,
hình
the minimum
hàm trên
implant
hàm dưới.
number that we
Nếu mà
can
ta
set
phục
is 4 dental
hàm trên
implants.
thì số cây implant nên lớn hơn khoảng 4.
According to McGill consensus, we should at least get 2 dental implants. And not just that, we have to consider about the arch.
Chúng ta cần nên cân nhắc về cái hình dạng của cung hàm nữa. Nếu chúng ta có một cái cung dạng chữ V ở hàm dưới thì chúng ta nên đặt cái cây implant ra phía trước một chút. Nếu ta có một cái hàm dưới chữ U thì chúng ta nên giảm cái cầu vòi nhịp vói đi. cái vị trí chúng ta nên làm giảm cái nhịp vói trên hàm cố định sau cùng, hàm sau cùng. Và nếu mà bệnh nhân của bạn muốn một cái phù hình cố định, chúng ta nên làm như nào? Thì tôi nghĩ là các bạn ai đã nghe đến phù hình all four, phù hình all six. Nhưng mà bây giờ thì để an toàn hơn thì ta nên đặt càng nhiều implant càng tốt, thì thường chúng ta đặt 6 implant. Chúng ta nên đặt ở vị trí răng cối lớn số 1, vị trí răng cửa bên và răng nanh. Bởi vì trong trường hợp này chúng ta muốn tách cái phù hình thành nhiều phần càng tốt. Đôi khi thì bệnh nhân muốn một cái phù hình theo kiểu truyền thống là chúng ta cần đặt 7 đến 8 trụ implant và tách ra thành các đơn vị riêng lẻ và cầu răng.
And this is from Dr. Mish. So Dr. Mish actually published this in magazine. So he talks about when we do a full arch implant prosthesis, how do we classify our restoration? So first thing, if you have a dental patient, you want to know how much tissue and bone support that you want to have.
Sẽ phải cân nhắc là bệnh nhân cần phục hình bao nhiêu phần mềm theo chiều dọc và chiều ngang.
So according to his classification, FP1 means that you are trying to restore as conventional crown bridge type dental
hình thái truyền thống chúng ta gọi là phù hình FP1.
FP2 type,
và với phù hình FP2 thì chúng ta sẽ có một chút chân răng trên phục hình chúng ta, và phù hình FP3 thì trên phục hình chúng ta gọi là giảm.
But also you want to replace the soft tissue.
Tức là trên phục hình chúng ta sẽ có cả răng và phù hình lợi giả trên phù hình trên bên chúng ta.
Okay, and that's going to cases. And I see many dental students here. And this is actually my very first dental case in 2020. So I want to share this case with you.
Tôi sẽ share ca này với các bạn.
So Belinda was referred to me from orthodontist.
Chuyển tôi từ khoa chỉnh nha và bệnh nhân mất răng 7 và răng 10.
So as you can see here, we have a little bit loss of the tissue vertically. And also you can appreciate that her crown, her tooth is pretty square and has a lot of texture. And this is the root angulation that is not too bad. Before I do any dental implant surgery, I still like to take some periodical things because that gives me the idea about how much bone that will have. Sometimes the CBCT doesn't show that well.
Đôi lúc thì cái phim CT không cho tôi cái kết quả quá là như tôi mong đợi.
I like to
trong đến quá trình thu thập dữ liệu,
data collection. So I like to take the intraoral photos and evaluate the ridge, especially from buccal and occlusal view. And another important thing is about protrusion, because anterior teeth, the teeth are inclined to incline. So you don't want to apply too much of excess loading on your teeth. So you want to check the guidance and to see where will be your future incisal edge going to be. And the next thing I did was the interim partial denture, because this patient is very young, so we want something she can smile with. So first we deliver an interim partial denture, and I try to evaluate the future gingival margin that I wanted to be. And also the good part about this is you can utilize this and do the dual scan. So that's what we did. And as you can appreciate here that I did the dual scan, and also you can appreciate how thin the bone is gonna be. So in this case, we decided to go with 2.9 by 10 millimeter. And because the space is very limited and you want to make sure you have an ideal implant position, so we decided to do this guided. So this is how it started. And then I just did a very simple mid-crestal incision and open the flap, and then place the implant surgical guide on the implant side and then did the guided surgery, and do the simple interrupt sutures. And after that, because you can imagine this is a 2.9, and the primary stability probably will not be too good. So what we can do is we can submerge the implant, put the cover screw on, and let the tissue heal. And in this case, we let the tissue heal for 6 months because we want the aesthetic outcome. And then, I graduated, so I transferred this case down to my co-resident. That is how it happens at school. And then this was a photo that my co-resident sent it to me. So here what we see is we have a custom gold-plated abutment here, and the angulation is still buccal. And here you can see that we place our margin right slightly below the future general margin. So between selection for custom healing abutment and angulated abutment, how do I select? For anterior case, I would like to know how deep the margin is going to be. If that's the case, I prefer custom healing abutment whenever is possible. And in this case, you can appreciate we are going to have a cement retain restoration. And then for abutment, we do have many different choices. And this is from textbook of Dr. Tunnels. And you can appreciate that we can choose the gold, titanium, zirconia if you have an aesthetic case, you really want very good aesthetics, or you can also use the PIC abutment. And nowadays I prefer to have the type base with the either the zirconia or E-mix if possible. And this is how it looks. And I wouldn't say this is perfect because you can still kind of see the tissue defect here, but the patient is really happy with that. And this was the final result. And another thing to be careful is patient's oral hygiene, because you want to make sure patient can keep really good oral hygiene. That would be the long-term success for the patient. Okay, and then the second case I would like to share is a full mouth rehab case. So this patient, he is from Dominican Republic, and he mentioned that he broke his teeth a few days ago, and as you can appreciate here, he's wearing the partial denture. He only wears the top but not the bottom. And this is a metal-based partial denture here. And he wants to get the dental implants if possible. So here we can appreciate a few challenges. First is the occlusal plan, which is the ideal occlusal plan. Anterior teeth, we have super eruption. Posterior teeth, we have a close spine, and also very like infraocclusion. And second thing is how much interocclusal space would you do here? If you just place the implant here, you can imagine that the implant position will be super buccal. So you might have a big cantilever that you want to avoid. Posterior seems fine, but you don't want to have a big step between anterior teeth and posterior teeth. And this is how patient present with a partial denture. So patient doesn't raise the vertical dimension. We still keep the tooth contact in the posterior. And another thing patient doesn't like is the canine position. He feels whenever he smiles, the canine looks really high. So how do I start? I spend a lot of time doing the prosthetic implant planning in this case. So first I evaluate the patient's vertical dimension. And this is when patient closes down at the maximum intercuspal position. And we don't just want to see patient from the frontal view, but also we want to evaluate patient from lateral profile view. If you see a cross-street facial profile, that is very likely patient has loss of the vertical dimension. And this is a repose position. So how do we get the repose position? Is you can ask your patients to speak, for example, like Emma, so they can open up the lips a little bit to get that rest position. And you also want to evaluate patient's smile and to see where would be the future crown and implant junction is gonna be. And I always like to take the diagnostic cast and photos if possible, because when patient is in the chair, we can see everything, but if patient laugh, we don't have anything. And although human body is considered as the best articulator, but you still want to simulate the movement on your articulator. So here we can appreciate that patient has a scissor bite, cross bite, and there are also some spacing issue, and also we miss a lot of teeth, and the Freeland attachment here is considered high. And second thing, in addition to CBCT, you want to take the panoramic film and periapical film, because that will give you the general idea about where is your bone level. And before we place any dental implants, we have to build a foundation well. That means ideally we should treat the periodontal disease properly before we do any prosthetic work. So the first thing I did was I referred the case to my periodontist. And as you can appreciate here, we have some deep probing and some breathing on probing, and some teeth are considered irrestorable. And although the mandible doesn't look that bad, but imagine if you want to restore the occlusion to an ideal occlusal trend, it might be really challenging. So treatment planning is actually a decision that between prosthetic and also periodontal. And the second thing I did here was I evaluated the vertical dimension. So there are several ways you can evaluate a patient's vertical dimension. You can just look at the facial height. So the lower facial height is defined as the distance between your nose and between your chin. So ideally, your face should be 1/3. And also you can test the phonetics or have your patient swallow and evaluate the vertical dimension. And the way I like to do, I feel this is more like objective, is you can make the landmark, one on the chin and one on the nose, and mark it with a marker so you know this is a distance when patient bite down. And then you can ask the patients to speak a word that will help them to relax and mark the second line. And this distance, according to the literature, if you have a class 1 dental occlusion, that should be 2 to 4 millimeters. And if you have class 2, the distance will get larger, and that will be 4 to 6 millimeters. And if you have a class 3, that will be around 1 to 2 millimeters. And then right now, I like to play around like analog and digital workflow, because I feel in this case, if I do the diagnostic wax up, I still don't have a big picture about where my occlusal plane is gonna be. So the first thing I did was after I got the diagnostic cast, I scanned it and put into the virtual articulator. And from here, we can estimate where would be the ideal occlusal plane. And then you can increase the height of your incisal pin, and that will open up the space for your restoration. So from there, I have a better idea about where to put my occlusal plane and dental implant. And then before I jumped into dental surgery, I still went back with the treatment planning carefully to discuss with the patient. So I got the diagnostic cast. And second thing I did was I would like to evaluate patients' overjet and overbite and get the ideal vertical dimension that I want to restore. So I made the wax ring. And this is pre-made in the lab. And then I set up the teeth chair side to get the ideal occlusion for aesthetics. And then another thing I did was because I increased the vertical dimension. So if you want to increase the vertical dimension, literature they have shows that the maximum you can increase is around 5 to 6 millimeters. So if you want to increase more than that, you want to have a device that can help you. And here I did a kind of go 6-hour tracing. define this like central relation position. And from there, I took a bi-registration. So from there, I can mount my cast at the ideal vertical dimension. And then I went back and had a discussion with the patients about which treatment option should we do. We can either do the removable option, just like where the patient had, and maybe do some onlays and crowns to level the occlusal print. Or we can do the bone reduction. Because in this patient, he does have a lot of bone. It's not like we have to do the bone graft. So in this case, we actually decided we can reduce the bone and do the complete arch fixed implant processes. And that would be the 016. But with either option, because previously I got my ideal vertical dimension with the bi-registration, so I'm not worried to go with the either option. And now if you want to do full mouth rehab, what we can do is we can do the stackable to supported surgical guide. And this will involve collecting the patient data. Patient data will be like patient scan, bi-registration, and diagnostic wax up. And in this case, although we decided to go with the complete arch fixed implant processes, we still want to keep the vertical dimension during the treatment, because implant is still healing, so you don't want to have too much force on it. So how we decided that was we decided to keep the third molar in place. We are not extracting at the day of surgery. And then here we have the anchoring pin, and we designed the two supported implant surgical guide. And second thing is you want to have a bone reduction guide. And again, this bone reduction guide is resting on your tooth. So that will give you an idea about how much you want to reduce your bone, and this can be really accurate. And then from there, you can plan your implant position. So nowadays, if patient can do 0-6, I would prefer to do that. Because for 0-4, let's say if you lost one implant, then it's very hard to restore, because there will be a lot of forces on the processes. But if you have 0-6 and you lost one implant, that is not too bad. And then we went on to design the implant surgical guide. So here we have in total 6 dental implants, and ideally it should be on the palatal side. So one thing I've been thinking about, would you say hybrid process is surgical driven or implant or prosthetic driven? I think that's the thing we have to think about. And this would be the implant position. So as you can see, this can be stackable surgical guide that will rest on the guide that previously we set. And then because we want to do immediate extraction and immediate loading, so we also designed a provisional restoration. And that was a long day. I worked with the para-residents, and we went through like surgical team together with the implant company, and we decided to do a surgery from 7 o'clock in the morning until 7 o'clock in the night. So that's a long surgery day for the patient. So first thing, before you do anything, you want to make sure patient's periodontal condition is really stable. So before we jump into the surgery, we actually had gone through the phase 1 therapy for 3 months before we do anything. And then we try on our implant supported guide, and it fit quite well. And then we went on to raise the flap. And here, as you can appreciate, because you want your guide to be really stable, so not just use your finger to be on one side, you want to use the anchoring pin that will help you to fixate really well. And then the next thing we did was we extract the teeth carefully. So for molar, if we want to place dental implants, a lot of cases we will see a lot of either periodontal disease or retain root. So you want to carefully section the tooth if possible, because you don't want to lose more of your buccal bone. And again, as I said previously, we preserve the third molar because that can serve as a guide for the surgical guide, and also we can keep the vertical dimension during the healing. And then here we utilize the piezo surgery that will help to cut the bone more precisely and also more evenly. And after that, we grind down any rough edges that will interfere with the implant healing, with the bone ruptures. And then you see here, so the implant surgical guide will raise on the top of the surgical guide. So they will snap on, so the position will be really stable. And from there, we started to place the dental implants diagonally, because you want the implant guide to be still stable after you place the dental implant. Sometimes if you place the dental implants one by one, you will notice that when you go to the other side, it's not that precise. So here we did like diagonally place the dental implants. And after we place the dental implant and confirm that we have a good primary stability, then we went on to choose the abutment that we want to use. And this is also determined before the surgery. And after we select the abutment, we put the temporary cylinder onto the top of the implant. And then again, here is a provisional restoration that rests on the top of the surgical guide, so it also snaps on. And the benefit of using a surgical guide is we can have ideal occlusion. Sometimes it might be a little bit missed, but usually it is not too bad. And then because you want these processes to go into patient's mouth, so we did a pickup. We connect the temporary abutment to the provisional processes using the compact resin, just to stick them together first, and then we unscrew the temporary cylinder and use the pattern resin to fill the back and connect to the implant processes. And this 3D printing provisional was inserted to the patient's mouth again. And because there will be multiple screw holes from the temporary cylinder, so we try to fill that with the PVS, and that can be easily filled. And then this was the provisional process delivery. And then we confirm with patient's smile, because this is a big surgery, so if after the surgery, what we should do is we should take a panoramic film and also the post-surgical CBCT if there is something you feel that might go wrong. And then also, I graduated again, so this was the transfer case. And this was the final photo that I got from my co-resident. So here, before you take any final impression, you want to make sure your tissues are very healthy. And you don't want to see any bleeding. It's normal to see a little bit pink, but it shouldn't have any oozing. And then for the materials, we decided to go with monolithic zirconia because we want the strength and also aesthetics. And these are the stand from the monolithic zirconia. So here you can appreciate that we increase the vertical dimension and get the processes aesthetically and functionally. And not just that, posteriorly we place the dental implants. It doesn't show well here, but we did place the dental implants because in order for processes to become successful, you want to have good posterior support. Your posterior support should support your anterior teeth, not just for aesthetics. That's for the long-term processes. And conclusion, I think it goes back to how we started. So before we do any implant surgery, we don't want to just jump in and place the dental implants. You want to have a careful planning that is multidisciplinary. So first, case selection. You want to go through all the medical history. And just like how we build a house, you want to build the foundation first and treat the active disease before you do anything. And for data collection, right now we have so much digital tool, not just CBCT or intraoral scan. Right now in our school, we have been trying to integrate with the facial scan and also a digital smile design as well. And after that, after you got your diagnostic test, you can either go with the analog workflow, do the diagnostic wax up with the traditional wax, or you can do it virtually, doing the virtual wax up as well. And from there, if possible, try to do guided surgery as much as you can, because that can make sure the position is ideal three-dimensionally. And eventually, you will go into the surgery. So surgery should be the last step, and then that can make sure you have the success prosthetically. And not only that, after the treatment, you want to make sure your patients come back. Maintain the oral hygiene and also the prosthesis. So last year, we have our Dr. Nepal, David Nepal, and he wants to say hi for everyone. So he reminded me this, like we really need the team efforts. It's from restorative team, surgical team, laboratory team, and orthodontic team. Yeah. Okay, and lastly, I would like to thank Operation Smile and Zinning for supporting us to come here. And this is such a pleasure to work with all of you. And I'm from dental medicine, so if one day anyone wants to come, please let me know. And I think our team also welcome everyone to come to the United States. And I'm an international student, so for clinical skills, I feel, as a dental student, I remember I care so much about my preclinical skills. But as time goes by, I realize that diagnosis and treatment plan should be the one we focus on. Clinical skills will gradually pick up. And with the internet, and for example, like we have this event, can really facilitate, we exchange and share our knowledge. I think that's a key message I want to deliver here. And that concludes my presentation.